Hello, everyone. Welcome back to the next lesson. In this lesson, we are going to talk about the procedures in mammography. So we will cover anatomy, pathology, how to position your patients, special need patients, and imaging procedures in this lesson. For the content specification, this is all you need to know regarding your anatomy or what will be asked on your test. This is from the ARRT website. So you may want to you can use this information, just make sure that you are able to answer all of these questions if it is asked. And if you do want me to do like another lesson where I am giving you questions, answers, and explanations, put it in the comment box if you would like to see a video like that, and I can make a separate video about test questions and answers for you to study and prepare for. Now we have localization terminology in mammography. Make sure that you know right breast, left breast, 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. Whenever you are looking at your right breast, where is 12 o'clock? Where is 3 o'clock? Whenever you're looking at your left breast, where is 6 o'clock? Where is 9 o'clock? You also have your quadrants, upper outer quadrant, upper inner quadrant, lower outer quadrant, lower inner quadrant. You have the tail of Spence at the top by your axilla. For your breast quadrants, whenever a patient has to come back for a diagnostic mammogram, let's say that they just had a screening mammogram and something was found on it, whether it was asymmetric tissue, calcifications, a cyst, some type of mass, they will have to come back for the additional views or diagnostic images, and you will need to know what part of the breast that we're looking at because you will have to read the patient's mammogram report. And there will be certain examples in there, like it may say there is asymmetry on the right breast or the left breast, or maybe calcifications. It will have on the report whether or not it was seen on the CC view, the MLO view, or maybe both. It will tell you if it was seen at 3 o'clock, 7 o'clock, 6 o'clock, how many centimeters from the nipple. So whenever you are working as a tech, you will have to know how to identify this on the mammogram image because it's not going to be labeled like this. So a radiologist they may have drawn measurements from that lesion or calcification to the nipple or from the nipple to that lesion, and then they will put in a report, hey, it's at 3 o'clock, 6 centimeters from the nipple, but sometimes they may not put it in there. So it's either good to know what area you're looking at or go and ask questions to the radiologist just to be sure that you're imaging the right area. The location of the breast, you have that the breast extends vertically from the clavicle, the second or the third rib, that's where it's located at. The breast meet the abdominal wall at the level of the sixth or seventh rib horizontally from the mid-sternum to the mid-axillary line. The breast can form anywhere along the milk ridge or line called the mammary line. So you have your mammary line extending from one side of each body from your armpits in the axilla or axilla to the groin region of the body. Don't forget that you have pectoralis muscles. You have your pectoralis major and your pectoralis minor muscle. You also have more terminology. We talked about this in a few slides ago, but you have four quadrants of your breast. Upper outer quadrant, know how it is abbreviated or the acronym, which is UOQ. And then you have your upper inner quadrant, lower outer quadrant, lower inner quadrant. And that's because we describe the breast as like a clock. So you will also see that we say 12, 3, 6, 9 o'clock. And then you have most cancers being found in the upper outer quadrant, where the axillary tail, the tail of breast, and the tail of Spence is located at. It is very important to know the anatomy of the breast tissue because you also want to make sure that you are getting a good image with the nipple, that you are seeing all the way past the pectoralis muscle or to the pectoralis muscle. And then sometimes, depending on how well a patient can position, You will see their lymph nodes too on the MLO views. So we do have different things affecting the way our breast is, whether it's big or small. We have age, menstrual cycles, whether we are gaining weight or losing weight, pregnancy, surgery, whether we're getting implants or breast reduction. So these are just things that you can keep in mind. You have your breast that is most secured at the superior and medial aspects. You have your breast being most mobile at the inferior borders and the lateral borders. Okay, we have an example of your breast anatomy. You want to make sure that you are including your pectoralis muscle, a nipple in profile, and the inframammary fold. When there are times where you cannot include this information, make sure that you are documenting it so that the radiologist can know and the technologist for the next year can know. Now we have the external anatomy of the breast. You have your IMF or inframammary fold. That's going to be that crease area at the bottom of the breast. So that is the most inferior portion of the breast. Although sometimes it's hard to image that breast depending on if a patient is in a wheelchair or if they just cannot position correctly, we still have to make sure that we are including like an IMF picture, especially so that we're not missing any type of breast cancer. So if you cannot get the IMF in there, you can always try to do another 2D image and get just an IMF picture, or also put it in the notes that patient could not tolerate adequate positioning if they can't. So just so the radiologist can know that you tried. And then on larger habitus patients, make sure that you are careful because the IMF can tear, and then whenever it does tear underneath their breast, it's going to make it harder and difficult to position them. And then you also have the skin of the breast that is going to be filled with sweat glands, sebaceous glands, or oil glands. You have your nipple that is the center point of the breast. It does have about 15 to 20 orifices. So know that. Also know your areola. Know that it's smooth, it's darkened, especially whenever a patient or a female is pregnant, it can become more darker during pregnancy. The breast during pregnancy, so it does become larger. The Montgomery glands become more prominent during pregnancy. And then you also have like a fatty lubricant that is going to help protect the nipple during nursing. So the pigmentation around the areola, it can become darker due to the hormones, the estrogen level in the patient's body. For your internal breast anatomy, the breast is composed of 15 to 20 lobes. The alveolar glands is the functional milk producing glands held by the lobule, and you have each lobe on the nipple can have 10 to 100 lobules. So also know that the terminal ductal lobular unit, or TDLU, can be divided into two different categories. So you have your extralobular terminal duct, your intralobular terminal duct. For the breast tissue composition, the breast tissue is made up of adipose or fatty tissue, glandular tissue, and it also have lymphatic vessels and blood vessels. Older women will tend to have fatty tissue, and then you have your younger women having glandular tissue. Adipose tissue is more radiolucent on the mammogram picture, meaning black. And then you also have most glandular breast tissues are found centrally and extends laterally towards the axilla in the upper outer quadrant. Your glandular tissue is arranged within the lobules. For the ligaments of the breast, you have your Cooper's ligaments. So that is going to help the breast stay up high. Whenever your Cooper ligaments become looser, your breasts tend to droop. So whenever you have Cooper's ligaments in your body, it's going to help keep your breasts up a little bit higher, especially if you do not have breast implants. So what affects our tissue composition? You have your hormones, the age you begin your first menstrual cycle, your hormones fluctuating. pregnancy and lactation, involution. You have menopause, perimenopause, weight gain or weight loss. You have a lot of vascular system in the breast. You have your heart, blood, and blood vessels. You also have your axillary artery, your calcified artery. There are times on the mammogram image that you will see a calcified artery. So whenever you are looking at the breast, you will see like an artery. And if you see anything white in it, like round white dots or areas on the actual mammogram image, especially in a line, that can be an indication of an underlying cardiac problem or a calcified artery on the breast tissue. And then this is an example of what I was talking about of the calcified artery. I have the green arrow pointing to it. So sometimes you may see this on the mammogram image. If you do, this is what it will look like. For your venous drainage of the breast, that is going to correspond with the arterial supply. You have your veins, which is larger than arteries. The largest of the deep veins is directly into the axillary veins. Your lateral breast drains the pectoral group and then to the axillary nose. You also have your lymphatic system. So if a patient is diagnosed with breast cancer, sometimes it may or it may not spread to the lymph nodes, depending on how soon it was caught, what type of breast cancer it is. So whenever the patient comes back, and if they or when they have to go to breast ultrasound, then the ultrasound tech would take images of the breast and also take images of the lymph node. If the lymph node is above the normal size, then the radiologist will recommend that that lymph node be biopsied under ultrasound. Most normal lymph nodes are less than 2 centimeters, and then you have about 20 to 30 axillary lymph nodes under your armpits. And if you forgot, the lymph nodes or the lymphatic system is going to help fight infections. Make sure that you know your 5 groups of axillary lymph nodes. You have your anterior group, your posterior group, lateral group, central group, and apical group. Here is an image of a male breast. It is very rare, about 1% for male patients to be diagnosed with breast cancer, but male patients can be and are sometimes diagnosed with breast cancer. So there is probably maybe 10 to 15 times that I have taken mammogram images on a male patient. Whenever they do come in, their mammogram images will be ordered as a diagnostic mammogram, and most of the time it may be due to pain or a lump that they are feeling around their nipple or maybe on their nipple. So the mammogram is going to be done just as if you're doing a female mammogram image. The patient is going to have the CC views, they're going to have the MLO views, and you're going to compress the same way. So the only difference is if a male patient come in and they have a lump or pain on their right side, they can't just come in and have the right side image. They have to have both sides image, and it has to be under a diagnostic mammogram order. You also have your cytology of the breast because there are times where patients have to have a biopsy. So it's important to know your epithelial cells, myoepithelial cells, your basement membrane. For your epithelial cells, that is going to be the inner layer. Your myoepithelial cells is going to be the outer layer. For a basement membrane, that is what's going to form a protective barrier against the initial infiltration of tissue by the tumor cells. Terminology used for breast imaging, you have circumscribed, which is rarely malignant, most likely will be a cyst or a fibroadenoma. You have microlobulated, which is suspicious for breast cancer. Obscured is going to have a hidden by superimposed or adjacent fibroglandular tissue. Indistinct is not going to have a clear margin, so it is suspicious for malignancy. And then most breast cancer will be the spiculated margin. Also, you have your common shapes, which is round, oval, or irregular shape. For your round shapes, whenever you see a mass on a mammogram or ultrasound, that's mainly going to be benign for breast cancer, maybe a fibroadenoma. For a circular or oval, that can be detected by the patient as a palpable lump or a palpable mass. That would be a benign mass, maybe a fibroadenoma or a cyst. Lobular shape is going to be like a scallop contour, and then irregular, that's going to be uneven in shape. It cannot be categorized as either round, oval, or lobulated. So those types of shapes is going to be suspicious for breast cancer. So the radiologist will recommend a biopsy. The borders or the shape around the lesions is very important. So whenever a patient do have to come back for a diagnostic mammogram, if calcification was seen on the screening mammogram or any other type of abnormality, they will either have to have magnification views for calcifications or spot compression. Breast ultrasound may or may not have to be, um, the patient may or may not have to go to breast ultrasound depending on what was seen on the mammogram. Maybe it's asymmetric tissue that wasn't smoothing out or flattened out with mammogram, or it could be a cyst, or the radiologists know it's probably a cyst, so they just send the patient over for a breast ultrasound. This is an example of spot compression. You can feel free to put it in the comment box if you do diagnostic mammograms or if you just perform screening mammograms. I know depending on if you're full-time or you're PRN or maybe you're close to retirement, most techs may just do screening mammograms, but I know a lot of full-time techs do diagnostic mammograms. PRNs can do them as well. It just depends on how often you work in mammography and how comfortable you are with talking to the radiologist and doing the spot compression. But I have the green arrow pointing to a spot compression device, and then you see the white arrow pointing to the actual lesion. And then you have your asymmetric breast tissue. This is going to also be known as focal distortion, and it's usually identified when comparing one breast to the other. For focal asymmetry, one of the breast tissue is different compared to the other. So that's why we have the patient come back as a diagnostic mammogram patient, and we perform those spot compressions to see if it will compress and even out the breast tissue. The patient will have to be in different views. So depending on where you work at, the radiologist may recommend or tell you that they would like for you to start with a true lateral image, and then you can do your CC view, or you can spot in your lateral and then spot in your CC view. So on the screening mammogram report, the BI-RADS score will read a 0 because the patient need additional images. So they will come back and have those spot compression images done. Once they have the report will generate whether or not it's benign, it's negative, if they need to follow up, if it's suspicious. It will have a different BI-RADS score number on there once they come back and get the additional images performed. This is your example of the asymmetry or asymmetric breast tissue where the red circle is over. With calcifications in the breast, the patient will have to come back. This will be a diagnostic mammogram. 9 times out of 10, the calcifications was seen on their screening mammogram. So when the patient do come in, depending on what your radiologist prefer, you would do a full true lateral picture, and then you would do your spot compressions with the magnification stand. The spot compression images will be in 2D. So it will not let you take the mammogram image in a 3D image if the magnification stand is on. So if you're not comfortable with doing diagnostic images, and if you notice an error once you put the stand on, that's because your images have to be in 2D. This is an example of breast calcifications. You have the green arrow pointing to the nipple, and then you also have it pointing to calcifications. When calcification do occur in the breast, the patient will have to do one or two things. Either they will have to come in and it will be benign and they do not have to worry about it, especially if it's stable over time, or it will be small or maybe suspicious for breast cancer. So the patient will either have to watch it for a short period of time, or if it's very suspicious, the radiologist will recommend a stereotactic biopsy. This is another image of breast calcification. When a patient do have to come back in for these type of diagnostic images, their doctor will order a breast ultrasound with this, but we will not perform, I say we because I also do breast ultrasound as well. We do not perform ultrasounds on calcifications or calcs because it will give like a streak artifact. So once the patient has been cleared in mammogram, then that order will be canceled. But it's also good to have it in because sometimes, you may have a doctor who do not know that these calcifications will cause streaking on ultrasound and that you can see it better under mammography. The different types of calcification, you have your coarse calcifications, your linear rod-like calcifications. So with the coarse-like calcification, is going to be larger than zero point 0.5 millimeters in diameter. Your linear rod-like calcification is larger than 1 millimeters in diameter. Those are most commonly associated with benign changes like ductal dysphagia. You also have your round calcifications smaller than zero point 0.5 millimeter in diameter. Your round calcifications larger than 1 millimeter are benign. Your casting type calcifications are fine linear branched calcification that can be fragmented with irregular contours. DCIS is associated with the casting type of calcifications. Amorphous calcification, which is going to be less than 0.55 millimeters in diameter. It can be concerning for benign or malignant. Your pleomorphic calcification is going to have many different changes and irregular in form, size, and optical density. It can appear single or in multiple clusters. Your malignant calcifications for DCIS or malignant calcifications are smaller than 0.55 millimeters. For benign calcification, the indication for it is smooth contours, high uniform optical density, evenly scattered, sharply outlined, spherical or oval, railroad tracks, the calcified arteries that I showed you on like a few slides ago, bilateral and evenly scattered, coarse, popcorn-like, linear, tubular, or rod-like. Is going to have an eggshell or an oil cyst. It may be large. A lot of patients always ask, and they may ask you what causes calcifications in the breast. And I always hear the radiologist tell patient it does not have to do with their diet. So it doesn't have to do with diet. It doesn't have to do with high caffeine intake. Breast calcifications are calcium deposits that develops in the breast. It is not caused by a diet. They may form from benign conditions such as a fibroadenoma or a breast cyst. So you may see those calcifications in a tumor, such as a fibroadenoma or breast cyst, something that is benign. It is important for patients to continue their annual mammograms, especially because it can be an early sign of ductal carcinoma in situ or DCIS, especially if those calcifications are tiny. You have your cyst, which is going to vary in size. It can become larger or smaller depending on hormonal fluctuations. Younger women, premenopausal women, and postmenopausal women taking estrogen may get a cyst or may have a cyst. Your galactocele is a benign milk-filled cyst with a high fat content. This is associated with lactation. It can be painful. So if it is painful and if it's bothering a patient and it's keeping them up at night, then the radiologist is going to recommend a fine needle procedure or where they get it aspirated. So a needle will go inside the breast tissue with a syringe hooked to it, and you will just aspirate the cyst or drain it. This is an example of a breast cyst. This was felt by the patient as a palpable lump. And then on the images, for the image that is far away from me, that is your mammogram. You have the white arrows pointing to it. For the image closer to me, that is a breast ultrasound. The white arrow is pointing to the enhancement. That's how you know when you see like a white enhancement like that, that's how you know that it's probably going to be a cyst. And then that round part of the cyst is black or anechoic. This is an example of a galactocele. This is on the mammogram image. Okay, we have our fibroadenoma, which is going to be like an oval-like lesion. Most common benign lesion in women younger than 25 years old, may be palpable for patients. It can range from 1 centimeters on up, and then the radiologist is going to recommend a ultrasound guided biopsy just to be sure. For your lipoma, this is a fatty tumor, radiolucent, and may be huge and covering the entire breast. You can easily identify this on the mammogram images, and it is not cancerous. Your hamartoma, which is also known as a fibroadenoma lipoma, which is a benign tumor. It is well circumscribed, round or oval mass. It can be seen as radiolucent or radiopaque on mammogram images. You have your example of a fibroadenoma. A fibroadenoma and a cyst is very common. I see these all the time in mammo or in breast ultrasound. An example of a lipoma, you can see from 2013 how it's kind of like small. It's almost like a nickel shape, and then you see that it's getting larger in 2014. You see it getting even larger in 2017. It's almost like, or it could be like a quarter size now in 2017. You have those round stickers on the breast that is covering up like a mole or a skin tag, which is very helpful because if it wasn't, you may think that's some type of pathology as well. You also have papilloma, which is a solid lump or wart-like growth in the breast ducts, composed mainly of mammary epithelium. Your ductal ectasia occurs when a duct becomes blocked. The area around the nipple becomes tender and red, causing a thick green, black, or sticky discharge. These are commonly found in women in their 40s and 50s. Your hematoma. So if a patient has like a car wreck, some type of car accident, maybe some type of trauma to their breast, this is going to cause a lot of pooling of the blood as a result of that trauma, and it may calcify and become like an oil cyst over time. Abscess and inflammation. These can occur at any time, but is most commonly occurring in lactating breast. So it can be red, hot, it can be painful whenever the patient come in and they come in for like an ultrasound. This can determine if it is a mass or if it needs to be drained. Fat necrosis is the death of fatty tissue in the breast, which can occur because of like an injury, a biopsy, radiation therapy. It may cause blood along that area and form like an oil-like cyst or egg-like appearance on the mammogram images. You also have your lymph nodes. This is going to range generally 2 centimeters in length. Anything more than 3 centimeters is considered suspicious, and it may or will have to be biopsy. It can be found in any quadrant of the breast. Although we mainly find it under the arm, it can be found in the breast tissue as well. Now you see the fat necrosis in the breast. You see how the green arrow is pointing to that. So make sure you know your anatomy, your pathology, how to pick it out on an image. Even if you are a technologist, it's good to know what you're looking at when you're working on the floor. This is your lymph nodes. You have the green arrow pointing to it. And then you also have the white arrows pointing to them as well. Your gynecomastia. This is a benign increase of tissue in the male breast. So sometimes whenever patients come in, like male patients, if they are having like a lump or a pain and they come get it checked out, sometimes or maybe a majority of the time it will be gynecomastia, and it does not increase the risk for breast cancer in male patients. Your radial scar is considered a risk for breast cancer. A lesion with no central tumor is how this would look. Gynecomastia for male patients, you have the red circle just pointing or highlighting over that area. This is a male patient's breast. An example of a radial scar. The high-risk pathology for breast cancer, you have your lobular carcinoma in situ, or LCIS. This is a precancerous lesion. This is not generally seen on mammogram images. It could be found accidentally during a biopsy for another abnormality. Atypical ductal hyperplasia is abnormal cells occurring in the milk ducts of your breast. So cells do have a higher than normal chance of becoming cancerous. It can be diagnosed by a biopsy. The patient must follow up on their mammograms. Atypical lobular hyperplasia is a precancerous condition that affects cells in the breast. It does increase the chance of having breast cancer in the future. Papilloma with atypia. This requires excision for a more concrete evidence or diagnosis. The proliferation that has the features suspicious for DCIS is with a papilloma. Now we have your malignant pathology. You have your ductal carcinoma in situ. This is a cancer that is confined to the duct and it does not invade the duct walls. It does account for about 22 to 23% of non-palpable tumors detected on mammograms. So whenever this is detected, it's detected on mammograms as calcifications. Invasive ductal carcinoma, a cancer that occurs when abnormal cells are growing in the lining of milk ducts and it invades breast tissues beyond the walls of the duct, which is the most common form of breast cancer. So invasive ductal carcinoma is the most common form of breast cancer. About 80% of all breast cancers are invasive ductal carcinoma. This is an example of it. So I have a lot of your pathology in this lesson. So just make sure that you're looking at it, you're paying attention to how I look on the images. This is an example of a breast cancer. You see how the mass is irregular and is spiculated, meaning you see those little lines pointing or coming from the actual mass. And the breast is fatty or has fatty breast tissue, and the lesion or cancer is white. This is why it's so easy to pick it up, especially if the patient has a 3D mammogram, because it can reveal this abnormality well. More malignant pathology of the breast, you have your invasive lobular carcinoma, an asymmetric lesion that is not associated with microcalcification. It does account for 10% of all breast cancers, difficult to diagnose. It accounts for a large percentage of potential malpractice lawsuits for failure to detect this on your mammograms. Ultrasound and MRI are much better at detecting invasive lobular carcinoma. So you have your pagan or pageant disease of the breast. This will have that eczema-like changes on the breast. So be careful to make sure that it's not eczema versus something that can increase your chance of getting breast cancer. It does affect less than 5% of women in the United States. It does occur as scaly, itchy nipple, and it can have a yellow, bloody nipple discharge. Your sarcoma, any cancer that is going to arise from the mesenchymal connective tissue, such as your fat, your nerves, muscles, cartilage, blood vessels, or bone, is extremely rare, accounts for less than 0.1%, can spread to the lungs, bones, liver, spleen, and skin very rapidly. The survival rate depends on the tumor size. Your lymphoma of the breast, also known as primary lymphoma or non-Hodgkin's lymphoma. This is extremely rare, represents 0.1% to 0.5% of all breast cancers. It usually presents as an enlarging, painless lump in the breast. Whenever you do position your patients in mammo, know your projections, CC and MLO projections. Your CC is going to be able to get your anterior, your central, your medial, and posterior medial portions of the breast the best. If you cannot get all of your tissue on your CC view, make sure that you add a 2D XCCL view for your MLO projections. This will allow you to image the extreme posterior or upper outer quadrant of the breast. Your CC stands for craniocaudal or caudal. Your MLO stands for medial lateral oblique. Make sure that you include the IMF on the MLO view. This is an example of your MLO and your CC view. The first picture is your MLO. The picture closer to me is the CCL view. And you see, if you're looking at the arrows and how the text is saying which anatomy is pointing to, you can see that the technologists who did this image did a great job. They got great muscle, they got a great IMF, and they got nipple and profile on both pictures. Whenever you are taking the actual mammogram image, make sure that you confirm the patient's name, date of birth, what exam you're doing. Match it up to their wristband if they have on one. Match it up to their order. Take their order and match it up to the actual computer. Because if you take an image on the wrong patient, what if the results come back as breast cancer? Now, the person that you should have imaged the image on, they do not know they have breast cancer, because now it's going to be hard to find who you really took the images on. And the person you took the images on, they won't even have the report. They won't even know that they have breast cancer. You're going to delay the treatment, going to delay the surgical option. So make sure that you have the correct patient. Don't be in a rush. I know it's easy to rush and try to get patients in and out, but you don't want to take images on the wrong patient. Another example of your CC and your MLO view. For your MLO projection, you are going to be able to get the pectoralis muscle the best on this projection. For most patients, your tube will probably be angled anywhere between 30 and 60 degrees. I know most techs will automatically angle that machine at 45 degrees, but on some patients, you cannot fit their body at a 45-degree angle. You may have to decrease it to 40 degrees. You may even have to increase it to 50 or 55 degrees. It just depends on the patient. Make sure that you are rehearsing the breathing instructions so that they can know when to hold their breath, how to hold their breath, so that you do not get motion on the images. For the positioning guide, MQSA recommends and requires that all mammogram images have a patient identification label, meaning the facility name, location, city, state, and zip code, the patient's first and last name, the MRN or medical record number, or a patient identification number, the date that the exam was done. The technologist's initials will be on there. The unit number for the mammogram room and machine will be on there. Your medial lateral or 90-degree lateral picture, you will mainly do this if a patient is coming back for a diagnostic type of mammogram, whether it's for breast calcifications, a needle localization, if a lesion was found and you are better at pulling them in medial lateral versus lateral medial. Medial lesions move up on the mammogram image and lateral lesions move down. Central lesions will not change. Medial lesions move up on the lateral from the position on the MLO. Lateral lesions move down on the lateral from the position of the MLO. So you will not see central lesions change on the MLO or the ML view. For your lateral medial, this is going to improve details of a lesion located in the medial aspect of the breast or high on that chest wall. The mammogram tube has to be turned to a 90-degree tube angle in order to image this. It is normally used to perform preoperative localization procedures of an inferior or lateral lesion that is more comfortable for patients. You also have your XCCL views if you cannot get the breast tissue all the way on a CC projection, your XXCM view if you need to get more of the medial aspect of the breast. If you cannot get a good middle part of the breast, you may have to do a cleavage view, especially if patient has like a larger breast tissue and you're cutting off anatomy, then you'll have to do a medial view. For the axillary tail, this is the projection that will visualize the tail of the breast and most of the lateral breast. This should not replace the MLO view. You still need to do the MLO view. You can do the axillary tail view as like a complementary view. This is an example of the cleavage view. You have the green arrow pointing to the cleavage. Axillary tail view, you see the light blue pointing to the axillary tail. Sometimes, not always, sometimes you have to do rolled position views. So just know how to roll your patients laterally, roll them medially to see a certain breast tissue. It can also help roll off or roll away dense breast tissue, especially for lesions. So get in the habit of just practicing, especially if you have like a good patient. Maybe you can practice on a patient or you can practice on another coworker, just so you can know how to do this. Not always, but there was one time where I had a radiologist who asked me to do a roll view, and thankfully I knew how to do it. For your implants, we can image implants. You want to make sure that you're taking the picture with the implant in, barely compressing it. You just want the compression paddle just to touch the breast to stabilize the breast. So this may give you anywhere from 2 to 4 pounds. And then once you're ready to take your implant displaced views, make sure that you are pushing the implant back, how you see demonstrated on the illustration right here. And then this is just more examples of breast implants, how you can push it back. An example of a ruptured breast implant. And then we talked about the magnification view, so I'm not going to go more in depth with that because I spoke about it earlier in the lesson. And then if you've seen my other lesson over the physics, I talked more about that as well. But I will say, and then you can still read this slide, but I will say it can increase patient dose because the breast tissue is much closer to the radiation source whenever magnification is used. A small focus spot is used with magnification image. So you can still read this image and you can pause it and you can still read this information. This is an example of the magnification stand and the paddle that is used. For your spot compressions, whenever a patient come in and they need more imaging done for like a suspicious area, this whenever you would do your spot compressions for like a suspicious abnormality. This is an example of the spot compression. And I did talk about spot compressions in earlier in this lesson and in my last video where I talked about the physics part of the machine. Your nipple in profile, you must have at least one image with a nipple in profile. So if you do not get the nipple in profile on both images, it could be one or two things. Maybe you're not positioning your patient correctly and make sure their feet is pointing towards the machine. Make sure that the breast is on the board correctly. Make sure the detector is not too low, it's not too high. If you cannot absolutely get it on the image, maybe it has something to do with the patient's body habitus because sometimes the nipple can roll under the breast. So just retake the image, check with the radiologist if they want it in 3D or 2D. Most radiologists I know, they just want the image in 2D. This is an example of a nipple in profile image where you see the gray arrow going to the nipple. And then on this one, you see that the nipple is rolled. So this is like an example of how you see a nipple is rolled and when to take another one. There are times where you may have like a patient who is difficult to position for your MLOs, and it can be because they have like maybe they have their sternum sticking out of their breast chest, or maybe they are kyphotic. So whenever situations like this occurs, you will have to adjust the tube depending on how the patient can tolerate the position. So you cannot always fit a patient at a 45-degree tube angle. You may have to increase it to like 50 degrees or maybe 55 degrees. For your male breast patient, if they do arrive hairy, then the compression paddle is not going to be able to keep the breast or the chest on the detector. So that will make it difficult to image them. Maybe a recommendation for scheduling to tell the patient to shave before they arrive, or maybe the facility may have like a shaving kit, but it does make it a little bit challenging to image male patients if they have like a lot of hair on their chest. The case study for this male patient is he felt a lump, and whenever you do position and take this mammogram, it's like whenever you're positioning for a woman for their mammogram. So it's the same way. The tissue is going to look very similar, like the anatomy. When you have a patient that has a protruding abdomen, keep the patient's abdomen out of the compression area. So have the patient step away a little bit from the machine. Make sure that they lean forward on the CC view, and then reduce the tube angle for the MLO view. So instead of automatically rotating the tube in a 45-degree angle, just reduce it to 40. See how that will work. And then you have kyphotic patients. At my facility, we can put in that it was difficult to position a patient because they was kyphotic. You can put notes in like that. If it's very difficult to position them, watch your tube angle so that you do not hit their sternum bone, or so that you do not make sure they fall, because whenever you are positioning patients like this, it may or may not be challenging for you. And then whenever a patient come in after they have had radiation therapy, it can be a little bit sensitive. So you may have to watch your compression. So if this patient can normally tolerate 30 pounds of compression, they may only be able to tolerate 10 or 15 pounds of compression. You just have to check with your patient. For a patient that has extremely large breast tissue, image the CC view in a 3D. If you clip the side, get an ACCL view. I always do this in a 2D, and normally the radiologists do not have a problem with that. For your MLO views, take two separate ones. Get a good image in 3D. If you do not get a good IMF, you can always redo that in 2D. For pacemaker patients, make sure that you ask the patient. Well, first, you should be checking at their previous mammogram images. Make sure that they do not have a pacemaker or a port. If they do, you have to make sure that you do not compress the pacemaker or the port. So, also document in the patient's chart, patient has a pacemaker, limited positioning or limited compression. For your wheelchair patients, it is very helpful if you put a pillow behind their back and get them to lean forward, or if you remove the arms from their wheelchair, if it can be removed, because it's very easy to image them if you remove the arms and if they can sit up. And also, whenever you are coming down with the tube, with the detector, make sure that you are not compressing their stomach or their lap. This is an example of a pacemaker seen on a mammogram image. This is an example of a chemo port seen on a mammogram image. You also have your markers if a patient come in and they have a scar from a lumpectomy, or if they have a lump, you can put your triangle to signify, hey, this is an area of concern. You can also put the little BB marker. I know one radiologist I work with, they prefer you to put a BB marker. Another radiologist I work with prefer you to put the triangle. And then you have the round circle for the mole marker. You also have the scar marker at the end closer to me. And then this is an example of a mole marker. If this was not marked, it probably would have been flagged as, let's say, some type of mass or cyst or fibroadenoma. So that's why it's good to put these markers so that come inspection time or come time when the radiologist is reviewing this, will know that this is a mole or a skin tag. Your surgical clips for whenever a patient has had like a lumpectomy. Whenever you have to image someone with very small breasts, make sure that you get like the smallest breast paddle that you can use. You can also use a rubber spatula. So, textbook wise, you think this is probably funny hearing that, hey, I can use a spatula in mammo. There are spatulas. Most clinics or all facilities should have a thin spatula. And whenever you have a patient with a small breast tissue, this is very helpful whenever you are imaging, because when you're coming down with that compression paddle, you will not hit your hand or your fingers because you have the spatula that will be in the way. Whenever you are imaging someone who is breastfeeding, make sure that you document this. Maybe even ask the radiologist if they should get imaged right now or if they need a pump and dump or pump and keep the supply, because it can make the breast tissue look a little bit more dense whenever they have like a lot of milk in their breast. This is an example of a lactating breast versus a non-lactating breast. If you can see the difference, the breast tissue just look more dense, which also can make it harder to see abnormalities. For pregnant women, um, just check with the radiologist to see the best way to go about imaging a pregnant patient, depending on what they're coming in for, their symptoms, their problems. Always check with the patient first to even see if they're pregnant, whether they're 30, whether they're 55, still ask. And then if they are, ask your radiologist what you should do, if they should have the ultrasound first, or if they should have the mammogram, or if the mammogram should be canceled until after they have given birth. The point of contact for questions should be the radiologist first. Now for your imaging, whenever you are imaging your exams, you have your 2D. I hardly ever see 2D being ordered now. If it is, it's because a patient went online and scheduled their own mammogram and accidentally ordered it as a 2D, or it's because someone just had a biopsy and they need a 2D image to see the clip placement. But other than that, most mammograms are ordered as a 3D because you can just see the breast tissue better. It removes superimposed breast tissue. So it just gives you like a better image and better picture of the breast. For screening versus diagnostic mammogram, and I talked about this in more in depth in my first lesson, patient care. If you haven't checked out that video, go check that out. But for your screening mammogram, that's your annual preventative mammogram. The patient should not have any lump, any concerns. For your diagnostic mammogram, is going to detect cancer, going to detect a cyst, fibroadenoma, why a patient may have a lump, why are they having breast pain. Most of the time, this is added on with a breast ultrasound. For your breast ultrasound, this uses sound waves. It does not use any type of ionizing radiation. It is safe unless you have a technologist doing the scan who does not know what they're looking at or what they're doing. You can perform biopsies under breast ultrasound. So, breast ultrasound is like a supplemental imaging for whenever a patient has a mammogram. If something was seen on mammogram, like a cyst or fibroadenoma or breast cancer, then they'll go over for a breast ultrasound. This is how a breast ultrasound image looks. You see the arrow pointing to the cyst. For your breast MRI, I work as a breast MRI tech, or I work as an MRI tech as well. With breast MRI, it is used to screen patients for high risk of breast cancer, for implant problems, if a patient was just diagnosed with breast cancer, for a patient with dense breast tissue, someone who is at high risk for breast cancer, depending on their medical history questions or depending on family history questions, they will have a breast MRI done. You have your sentinel node mapping, which is going to check to see if cancer is in the lymph nodes. If the results are negative, the cancer is present only in the breast. So after they have the node mapping done, if nothing is seen in the lymph node, the cancer is still in the breast. For a breast MRI, the patient will come in, have to lay on the table on their stomach because that's how the camera is. They will have to have contrast. They have to fill out a screening form to make sure they do not have any metal in their body. The scan will take about 20 to 30 minutes to perform. They cannot have a stimulator or a pacemaker and just go in the room. They cannot do that. If they do have a pacemaker or a stimulator, we have to do further research to even see if they can still have the scan done, if it's safe for them to have it done or not, because not all pacemakers are not safe or unsafe, and not all stimulators are unsafe. Depending on the device and who made it, it can go inside the scan room. If someone is operating it and turning it into the MRI scan, this is an image of a breast MRI. If a patient cannot have a breast MRI, it could be because they are allergic to the MRI contrast. So if you or someone say they are allergic to iodine, that doesn't mean they can't have an MRI scan, because MRI does not use iodine. It uses gadolinium. So make sure you know that too. It uses gadolinium, not iodine. A patient can have an MRI scan if they have a pacemaker or a stimulator, if it's MRI conditional, meaning it can be programmed. They can have it based off of the camera that has to be used to image a certain part of the breast, which actually, this is a little bit beyond what you really have to know, but since I don't know what will be answered or asked to you, I put this all in there so that you can have all the information you need to know about a breast MRI. Breast implants are fine, but if the patient has breast tissue expanders, they are not fine. So the patient will have to hold still the entire time. You also have for procedures like biopsy procedures, whether it's ultrasound, MRI, or stereotactic in mammo, the patient has to sign a consent form that will go over the risks, the benefits, any alternatives. They will also have a clip placed in their breast. If the breast tissue where the abnormality is found, if it's benign, the clip will stay in their breast. If it's malignant for a breast cancer, that cancer and the clip will come out during surgery. This is an example of a clip that was placed in the breast. And then this is how you will set up for your biopsy tray. The needle will vary depending on which radiologist is performing the scan because they all have their preference. And then you will have numbing medicine. This is an example of a stereo biopsy chair and the device that is used. For fine needle aspiration biopsies, you're going to obtain that sample or specimen with a 22, 23, or 25 gauge needle. So this is the fastest and the easiest biopsy method. You do have rapid results, but it is less accurate than a core biopsy. No stitching, no scarring. You just draining out the fluid. Needle localization. This is for a patient who has a non-palpable lesion or calcification. The procedure is done before surgery. So the hook of a wire is going to be approximately 1 centimeter beyond the lesion. This is an example of the wire. For your cyst aspirations, if a patient come in, they are uncomfortable, you're going to aspirate to see or get the fluid out to hopefully relieve the pain for the patient. This is an example of a needle going in for a cyst aspiration. This is an intracystic papilloma. You do have to send your specimens off to the lab, and then you also have a specimen radiograph or x-ray image that has to be taken to confirm that the lesion or the calcifications were removed. This is an example of the specimen radiograph. You see your clips, you see the lesion size. Whenever you are getting rid of your sharps, make sure that no one is around. Make sure that you're not just running in and out with the needle in your hand. Always use your surgical sterile gloves whenever you are setting up the biopsy tray. You cannot use the regular gloves that is in the room because those are not sterile. Disinfect the equipment before and after the patient. All right, so we are done with this review lesson. I know it was a lot. Um, if you enjoyed this review lesson, can you please give it a thumbs up for me? So, a quick summary about it. Mammography is a rewarding modality within the radiology field. Technologists must have empathy, patience, and passion to work in mammo, so you cannot be rushing a patient in and out the room. You have to be compassionate. You have to be patient with them, especially if it's their first time or if they are in a wheelchair, if they're nervous about their results. Empathize with them because they're nervous. They do not know what to expect. Our skills are enhanced and patient safety is increased whenever we are efficient, educated, knowledgeable, and professional whenever we are performing our mammography duties. Always remember, this is very important, safety over speed. Do not become complacent at your job. You will make mistakes. You will image the wrong patient. So document, document, document. Always document. Do not skip this step. It does not take long to document. It will save you in the future if someone has to look back on these notes, especially if you have any complaints. If you have where someone comes in and they forgot which side, you have concrete notes in the system saying the patient told me this, or the patient could not perform this, or the patient could not tolerate compression. You can put all these notes in the chart. So I appreciate you all for watching. If you made it this far, could you please give the video a thumbs up? You can also feel free to subscribe. I have a lot of lessons on my channel. I have other things I do on my channel. You can just check out the playlist if you want to subscribe. If you want me to do another video where I'm doing questions and answers, put it in the comment box. Let me know, and I am more than happy to put review questions, answers, and explanation. I want you all to pass your test on the first try. So every test I've taken, I tried to pass on the first try. I did pass on the first try, but when I was studying to know the information, to retain the information, and so that I can pass it on the first try. So if you enjoyed this video, please give it a thumbs up, and thank you all for watching. If you have any questions, feel free to leave it in the comment box. I look forward to reading your comments or answering your questions. Bye.